All right, so I wanted to talk to you guys about hand consults and how to survive hand call as a junior resident in orthopedics. And I think to do this, you kind of have to review some of the basics of hand again, just to make sure everybody's on the same page. So we'll identify surface landmarks so you can know how to call in a consult. Obviously, you need to know how to correctly identify the bones in the hand and the wrist, both on AP and lateral radiograph. We need to be able to just define some common terminology in terms of range of motion. I think that's one of the most confusing things when you initially start talking about hand motion, particularly in the thumb, and then learn how to manage the most common hand consults that you're going to see. At the end of this, if we have time, we'll go over proper techniques for wrist and digital blocks, and then hand splinting. So at first, this is our basic outline you can see here. So hand anatomy, just remember that when you talk about hand wounds, or when you're calling your senior resident or you're calling your attending to discuss hand consults, you want to make sure that you're talking about it related to the actual superficial hand, right? You're not talking about it related to the bone. When you're talking about fracture, you're talking about the bone. But when you're talking about lacerations, you want to know where it is relative to the creases. And if you look at your volar hand, there are a lot of creases there. And you're talking about them relative to the DIP, PIP, and then the proximal digital crease. And then the distal palmar crease is probably the most important in the palm that we talk about. And then you have your thenar and hypothenar creases, as well as wrist creases. So those are three creases that you really should know about when you're looking at your hand. I think everybody knows that the reason we care so much about the distal palmar crease is that's actually where the metacarpal MCP joint lies. And so if you're splinting the wrist, we don't want you to splint past that line because we don't want you to immobilize fingers. As everybody knows, in distal radius fractures, fingers are what get stiffest the fastest, and so we try and prevent that by keeping our splint below that level. Now, other landmarks that you can see when you look at your hand, obviously your IP creases associated with your finger, and then your thenar and hypothenar eminence, and then your wrist creases. So people usually have 2 or 3 wrist creases. The distal wrist crease is actually the most reliable of them all, and the distal wrist crease actually goes over your scaphoid tubercle and your lunate. So when you're trying to figure out that from like an anatomic landmark, if you're looking to see where the wrist joint is, that's where you're looking at. So if you extend your wrist on the radial side, you can actually see a palpate your scaphoid tubercle. Obviously on the ulnar side, you can palpate your pisiform. And so those are landmarks that you should know. This is just a real human hand so that you can see what it looks like relative to those creases, but they do exist. Take a look at your own. Now, the back of the hand doesn't have a lot of creases that we really need to talk about. You will see knuckle pads over your IP joints, and that's really about the only creases that we talk about in the back of the hand. But important things to know from your hand is when we talk about the tip, the fingertip, we're talking about the paronychium, right, which is in the entire tip of the finger. You can see that the most distal aspect is the hyponychium. The part down by where the nail inserts is called the eponychium, and that little white sort of half moon that you see is a lunula. Remember that the proximal portion is a germinal matrix, which is the portion that we really care about in terms of getting your nail to regrow, and then it goes into the sterile matrix later. But the entire thing is called paronychium. Obviously, an infection in the surrounding area is called a paronychia. Right? And the reason we care so much about nail bed injuries, as you can see on this image on the right here, that with a nail bed injury, if you have a crush, there really isn't much distance between the actual fracture, if you have a fracture for the distal phalanx, and the nail bed, right? It's just a few millimeters that lie in between, so that's why most of these injuries are considered open fractures. Now, it doesn't mean that we're taking these to the OR. The outcomes are relatively equivalent, so we let you manage these in the emergency room, and we will go over kind of management of nail bed injuries as well as amputations, right? But this picture just gives you a nice relative location of where the sterile matrix is, right at the tuft, kind of right where the tuft merges where the body of the distal phalanx, and then you have the germinal matrix proximal to that. And most of the germinal matrix is covered by the eponychium, or the eponychial fold that you'll see here. And then again, when you look at the bottom part of this picture, you will see a cross-section of the finger And what you see is these pockets of fat here, which are obviously very compartmentalized, and that's what you are divided. And when you have a felon or an abscess in the finger pulp, this is why we want you to split all of these up, because you can see that these are little tiny compartments that all need to release the pus from them. Now, hand radiographs. So you should be able to see all of the hand on a hand radiograph. It's focused on the metacarpals, but you should see the distal phalanx, middle phalanx, proximal phalanx. You should also be able to appreciate the carpals and the metacarpals, which you can see here on imaging. You should be able to name all bones, but looking more specifically at wrist radiographs, right? When you think about how you're going to remember these bones, because you may start residency and not know them, and that's okay, but you need to learn them, right? You're going to see a lot of fractures over the years related to these and a lot of normal x-rays of the wrist. There are many things, and you probably have some mnemonic in your head, and it may be, there's two primarily that come to mind, but the one that I like to use the most is so long to pinky, here comes the thumb. The reason I like this is it starts with a scaphoid, it goes all the way around, and it circles back towards the thumb. So you're starting on the thumb side, walking towards the pinky. So long to pinky, here comes the thumb. So you're always starting with a scaphoid and you loop back around. Now, finger radiographs. It's really important to remember when you're seeing consults, when you're triaging consults on the phone, whether it's coming from the pediatric urgent care or the ER, that you make sure that you're actually looking at the appropriate x-ray, right? If you're getting called for a proximal phalanx fracture or a middle phalanx fracture, then you actually need to see a finger image, right? Because oftentimes if they show you hand x-rays, the proximal phalanx are obscured, the middle phalanx may be obscured, you're not appreciating a true lateral of the PIP joint, right? So if you look at an image on the left here, you may say it's a non-displaced fracture. You may not get a great view of it because it's an oblique view. What you really need to see is the image on the right here, which gives you a true lateral of the joint. And what you're looking for is to make sure that the joint articular surface is concentric, right? You should typically be able to draw a line up the dorsal surface of a finger, and everything should line up well here. And we're really looking for articular congruity more so than anything. And so don't accept an oblique film when you really need to look at a true lateral of the joint. And you can see that here. So what I look for when I take these into fluoro is, you may get a phone call, if you ignore this fracture up here, you may get a phone call saying, hey, we just have a volar plate avulsion, can we have follow-up? And you want to be able to look at that and say, gosh, I can look at this and tell you that that PIP joint is concentric, and I'm fine with that being buddy taped and starting range of motion. All right, moving on to hand motion. So when you talk about hand motion here, I think everybody knows what supination and pronation is. What I always try and remind you about in hand clinic is that you can get really fooled by position of the shoulder relative to where the hand is supinating and pronating. And so if you abduct the shoulder, if your wrist is in neutral, it looks like you're fully pronated, right? So you should have the arm adducted into the side. You can actually hold somebody's elbows into their side and then check supination and pronation. Now remember, if you need to put a pen in their hand, it's a good way to check to see how much they can supinate on one side versus the contralateral side, and do the same in pronation. In the bottom image, you'll see wrist flexion and wrist extension. Now remember, when they're in neutral, that's 0 degrees, and extension is 0 to 90, and flexion is 0 to 90. And then ulnar deviation and radial deviation. Now we don't measure these a lot in clinic, but you can see that you can ulnarly deviate more than you can radially deviate. So usually it's about 40 degrees of ulnar deviation and 20 of radial deviation. And then finally abduction, which is away from the body, and abduction. Now I think everyone understands those, but some things that tend to be a little bit more confusing for people is how do you describe thumb motion? And we'll go over all of these. So when we talk about thumb flexion and extension, and most of the time when we talk about that, we're talking about the IP joint of the thumb, and you can see it flexing and extending here, right? So it's coming away from your palm. Opposition is a combination of flexion and supination, so it's really bringing your thumb to your small finger, as you see in this image here. Now, there are two types of abduction when we talk about abducting the thumb, and it's important to note because these are actually two different nerves that are allowing this motion to happen. You have palmar abduction. So if you lay your hand flat on the table with your back of your hand on the table and the palm facing up. Palmar abduction is bringing the thumb up away from the table or your flat surface, so in perpendicular to the palm, right? That's palmar abduction, and what you're checking there is APB, remember, which is innervated by the recurrent branch of the median nerve. So that's palmar abduction, right? And then radial abduction, if you put your hand flat on the table with the palm side down, radial abduction is bringing your thumb away from your index finger, right? So that's two different motions, and radial abduction is done by the PIN, right? So that's what radially abduction is doing. So it's important to note those two because you may be assessing somebody and you really need to make sure that you know which one you're doing. So when I check median nerve function, I actually check pure palmar abduction because I know that APB is fully innervated by median nerve, right? And so if you're radially abducting, it's checking PIN function. And then the final thing that's important is retropulsion of the thumb. So if you have your palm flat on the table, palm down, it's lifting your thumb up in the air. That's retropulsion of the thumb. So that also is checking your EPL function or PIN function. All right, so right now we're really going to talk about the ER hand exam, and I'm underscoring it for the ER because this is what you need to know how to do, kind of a dirty and quick exam when you're in the emergency room so you can document what you need to document and get the important exam, obviously at the time of injury for a patient, which sometimes is inhibited by patient pain, whether they've been previously numbed up by the provider or whatever, but we'll go over this. So when you think about the ER hand exam, age, hand dominance, occupation is always helpful. Really, anytime you're presenting any upper extremity patient, you should say age, hand dominance, occupation. Mechanism of injury, right? So what we really want to know is what was it, not just like with a sharp object. If you actually know what the object is, it really helps us differentiate because it can determine like a crush injury versus a sharp laceration. And in the setting of something like a replantation, it's important to know this because if it's a crush, it's a much larger zone of injury and the chances of replant are much lower. Whereas if it's like a sharp machete, it's a very short zone of injury and the replant chances are much higher. And obviously onset, location, and duration. So it's really important for us to know how recently this happened, particularly in the setting of an amputation or a potential replant, because we need to know what the ischemia time is, whether it was warm or cold, whether it's been preserved appropriately, and then really moving on to the exam, right? And so when you think about the exam, we're talking about the same thing that you do in any other exam. The first thing you want to do is look and document what you see. And most of the time, these are going to be open wounds. They're going to be infections. And you need to look for those. You look for surrounding warmth, erythema, fluctuance, and you document all of that. If you need to take a picture and walk out of the room before you call in your consult, that's very reasonable to do. It helps you remember what finger that you're talking about, because certainly I and other people have messed up fingers when we like call in, or write notes. We say it's right ring finger when it's really left index, things like that. But, it's always a good, you can have a picture of it and use it for reference later. So remember that when you look at the wound, document it based on those creases that we talked about. You can document the angle of a laceration, right? So if you're talking about if it's between the DIP and the PIP crease, you can say extending from the radial border of the DIP to the ulnar border of the PIP crease. Look at the resting position of the hand in the setting of tendon lacerations. That's a really good way to see what the resting cascade looks like, right? So normally if you just have a hand, if you take your hand and sit it flat on the table on the ulnar side, you can see that your small and ring finger flex more than your middle and your index finger, and so that's a normal resting cascade. Also, there's that tenodesis effect, so when you extend your wrist, your fingers flex. When you flex your wrist, your fingers extend. That's a good way to check tendons too. And then move on to sensory exam. So inspect first, sensory, do your 2-point discrimination. Whether you have a 2-point discriminator, whether you get out a paper clip and look for 2-point discrimination, you want to be able to document that. It's great because it gives you time point A. If it's something that you're worried about, like a progressive carpal tunnel, then you can check it again and you have a very reliable number to refer to, because you know that if it was 6 millimeters at time 0 and then 3 hours later it's 10 millimeters, and that warrants a phone call because it's progressive numbness. So you want to look at that. Once you've done your sensory exam, then it's okay to do any type of block that you need to do to look at the rest of the exam, right? But do the sensory exam first. I can't underscore that enough. And then you can move on and do your motor exam and your vascular exam. So I always put this picture here because it's really important. A lot of times you're going to see bloody fingers in the ER and you're going to think they're perfused because they're bloody. Now, remember, that's not always a case. So this was a case when I was a fellow, and this was billed to me as a perfused finger with just an open fracture. When I opened it, both arteries on both sides of the fingers were lacerated, and it's just a lot of blood, right? So clean it off, get a good exam, get a good picture of it if you're going to do it. As an attending or as a chief resident, when we get consults, it really doesn't help us when you just take a photo of a bloody, mangled hand and send it to us. So it does help if you kind of dry the blood off and at least get a decent picture if it's a very mangled hand and we don't know exactly what we're looking at. So if you're looking at this, this is just to show you a finger where the cascade is off, right? So this is a preoperative patient who most likely, if you look at this, you say, okay, I think there's a flexor tendon injury. It's most likely FDS and FDP based on the positioning of the fingers. The cascade of all of the other fingers look normal. You can see there's a little punctate laceration at the proximal palmar crease here over the ring finger. So other things that you can check in the setting of fractures, you can look at. Right, so here is a picture of a finger that looks rotated in full extension. You can see that the distal aspect of the distal phalanx is ulnarly deviating. And then when you actually have flex down, you can see how much more rotated it looks and how debilitating this injury would be if you didn't take care of it. So moving on to the sensory exam. So what nerves provide sensation to the hand? When you look at this, remember that there are 3 main nerves, the median, the ulnar, and the radial nerve. But when you talk about the median nerve, you have the palmar cutaneous branch, and then you have the digital nerves to the thumb, index, middle, and the radial half of the ring finger, right? So remember that those are 2 different nerves that provide sensation. The palmar cutaneous branch comes off about 5 centimeters proximal to the wrist crease, and the digital nerves come off from the proper nerves distal to the carpal tunnel, right? So those are actually different nerves that come off the median nerve. So in the setting of somebody that has acute carpal tunnel, their palmar cutaneous branch distribution should still be totally normal, but their finger sensation should be diminished. Same goes with the ulnar nerve. Remember that the ulnar nerve also has a dorsal ulnar sensory branch that comes off about 5 centimeters proximal to the wrist crease, and it goes dorsally to provide the ulnar half of the hand, and then digital nerves to the small and ulnar half of the ring finger. And then finally, the dorsal radial sensory nerve branch, which comes out at about 9 centimeters proximal to the wrist crease and then splits into several branches at about 7 centimeters proximal to the wrist crease, and that does a radial side of the hand. So here's a nice, innervation. So do remember that when we talk about the thumb, the back of the thumb is mostly the radial nerve, but you also see contributions from the distal aspect of the musculocutaneous, which is the lateral interbrachial cutaneous, which can provide sensation. You have palmar cutaneous at the proximal aspect of the wrist crease from the median nerve. So that's a very variable area to find sensation. So when you're thinking about how to do this quickly, and you're trying to assess sensation, it's index finger for median nerve, small finger for ulnar nerve, and then the dorsal first web space for your radial nerve sensation. When you talk about doing 2-point discrimination, you could take a normal paper clip and you can bend it in half. And when you are assessing somebody for 2-point discrimination, there's only enough innervation density at the fingertips. And so you can't get 2-point innervation on the palm, you can't get it on the forearm, you can't get it on the leg. Don't try it anywhere else except for the fingertip. And really what you're doing is you're pressing with those 2 points only until the skin blanches. So you're not indenting the skin, you're just doing it until the skin blanches. And you're asking if they can tell you the difference between 1 point and 2 point, right? And then you want to document what's the narrowest that they can tell you. What I do is I say 6 is the lowest I'm going to go. I don't need to go down to 4 millimeters. I go from 6 and above, given that the 6 is the high end of normal. In kids, it's really hard to do this, and so when I document this, you're documenting 2-point discrimination. You always start documentation starting on the thumb side and going to the small side. And so if it's, let's say the index finger sensation is out on the ulnar side, I would say it would be thumb would be 6, then index would be 6 on the radial side, 12 on the ulnar side, and then you go back to documenting each finger. And usually you document it by, it would be like 6/6.12/6/6. Or you could also write 6/6R.12U and then continue. And then moving on to the motor exam, right? So we talk about same nerves, median, radial, and ulnar, and the only difference is the median nerve also has the anterior interosseous nerve that you're going to be using to assess, and it has a recurrent motor branch. Radial nerve has a posterior interosseous, and then the ulnar nerve is just the ulnar nerve. So if you're talking about quick and dirty, remember that median nerve thumb is palmar abduction, right? So bring the thumb up out of the palm. If you're going to add opposition, it's touch the tip of your small finger will get you that abduction in there. Anterior interosseous is the AOK sign. Ulnar nerve, spread the index and long finger apart, right, giving you the P sign. And then the radial or the PIN is retropulsing the thumb, bringing the thumb from flat on the table up into the air. So if you talk about the how you can do it here, you can see it in these images. On the very image on the left is opposition, right? So that's APB, and you can see the APB muscle firing here. AIN is the AOK sign. Ulnar nerves is the dorsal interossei, and then thumb is, this is retropulsion of the thumb, or EPL. Sorry about that. Sorry, in this image here, right? So you can tell that there is probably a injury to FDS and FDP. When we talk about the vascular exam, remember that, number one, looking at clinical appearance, right? If you see a very white finger in the setting of all the other fingers being red, that is a good sign that the vascular system is not working. You can check the radial and ulnar sides, so you can get out a Doppler and you can look at, and you want the pinpoint Doppler, not like an OB Doppler. And you can usually Doppler all the way up to the PIP joint on both sides. You can do an Allen's test both at the wrist or at the finger to assess somebody's finger. That's called the digital Allen's test, and that's where you occlude one side, you flex the finger several times until it turns white, and then you let go to see if it reperfuses. And then always you can get out your Doppler. But remember that about 80% of people have a contiguous superficial arch, right? So even if you have a laceration of the ulnar artery, it should be able to be perfused for the radial artery. But there's still 20% of the population out there that doesn't, so you can't just tie off every ulnar nerve every ulnar artery or radial artery. And so that's why you have to consider assessing, right? And now you may have a spurting ulnar artery, but you say, I'm getting a really good distal pulse. That's maybe because the arch is working, right? So it's not that the ulnar artery is intact, it's that they're actually getting retrograde flow through the superficial arch. All right, so we're going to move on to hand consults and how I categorize hand injuries. And when I think about hand injuries, I think about them on emergencies, which means what's going to get me out of bed tonight. Urgencies, what needs to be done in the next 24 hours. Urgent follow-up, ideally seen in my clinic in the next 1 to 5 days. Routine follow-up, what can I see in the next week or 2 weeks, and then what can be managed in the emergency room or with your primary care doctor and we don't need to see. So hand emergencies are typically broken down into replants, revascularizations, Flexor Tenosynovitis, which I mean acute Flexor Tenosynovitis, ideally that's happened within the past 24 to maybe 48 hours, but doesn't have actively pussing out fingers. Compartment syndrome, acute carpal tunnel syndrome, and high pressure injection injuries. And the only one that probably isn't included here is necrotizing fasciitis. So here's just an image of a replant. We'll talk about how you manage those. In the field, you want to control it with direct pressure. Now, most of you aren't going to see these in the field, but on presentation to the ER, but oftentimes they do come with a tourniquet on. So your goal is to take that tourniquet down and assess the bleeding yourself and to hold pressure. And this is often can be for 45 minutes to an hour. So find your friendly ER volunteer or medical student to help you with holding direct pressure before you say that it won't stop bleeding. Don't use any clamps because this just extends the zone of injury, and obviously elevate the arm, right? Other things, save all the parts. So it's your job when the patient shows up in the ER to manage that part. So you can take the part, get it x-rayed, so put it on the same x-ray as the amputated portion of the remaining limb. Get an APN lateral so that we can assess zone of injury. Needs to be covered with a moist gauze or a moist towel, and then that puts in a bag that goes on ice. It does not go on dry ice. That will actually cause death to the tissues. And then get them to the OR as soon as possible. So this usually means a call to your senior resident, fellow, and attending just to make them aware of what you're actually doing, because frequently we want to look at x-rays and assess whether this is a potentially replantable digit or it's a replantable patient, which all those things need to be considered. Do remember that when you are assessing somebody in the emergency room that it is important to assess the patient in addition to the injury. Oftentimes in the setting of amputation, there are other concomitant injuries that can get missed because there's so much bleeding or extravasating coming from a wound that, like chest injuries, don't get assessed. The amount of blood loss doesn't get assessed. So it's really important to consider that, right? So evaluate for other injuries, do a complete but brief assessment. Make sure tetanus is up to date, make sure they've gotten antibiotics, generally wash the wound out, get a good history, right? Timing of injury, as we talked about before, knowing what the mechanism of injury was, what the actual amputation was caused by, always is helpful, and then do your physical exam and get the imaging and include both parts. So the bleeding arm that won't stop, you're going to get one of these consults in the course of your residency here. We've had several over the past weekend. This can be two things. Number one, it can be a tourniquet is up and it's barely up above the diastolic blood pressure, and it's really just venous bleeding, which happens frequently. So do let the tourniquet down, do apply pressure for a long time, and then do an exam. Now occasionally it's a partial laceration to like an ulnar artery or a radial artery, and it may stop for a while, then it starts up again, and that's usually a partial laceration, which doesn't clot off. Or it can be just a large lumen vessel like an ulnar artery, but most of the time, with plenty of pressure, all bleeding will stop, and obviously check to make sure that the hand is perfused. So call your friendly, medical student to come in and help you, or your friendly volunteer. Let the tourniquet down, assess the wound, direct pressure. When we talk about revascularizations, it's really the same principles as a replant, right? We want to know, is it finger viable? What do x-rays look like? What's the extent of injury? What is the function of the finger that's going to remain, right? So oftentimes you have to have a conversation with the patient as to, even if we are able to fix these fractures, most likely your hand is going to be pretty non-functional, or the finger might be pretty non-functional because you may have a segmental injury. So those are always questions that we have to have. But you want to make sure that the hand is perfused if we're doing revascularization, right? So get that Doppler out, do a good assessment, clean the hand off like I mentioned before, take good pictures, and do a good exam. So emergent flexor tenosynovitis. Like I mentioned before, this is really an acute flexor tenosynovitis, so ideally, like, the perfect patient is somebody that's had a hand puncture within the last 24 to 48 hours, acute onset of pain, swelling of that finger, and inability to move the finger, and tenderness. So remember the Knavel sign. So there's 4 signs. It's the flexed finger. It's held in the flexed position. It's fusiform swelling, right, or a sausage digit. Tenderness, palpation of the flexor tendon sheath. So when you palpate all the way to the fingertip, all the way into the palm, they have pain, and pain on passive digital extension. This is probably one of the most common consults that you're going to get that's not actually flexor tenosynovitis. It's just maybe cellulitis. It might be an abscess. It's your job to make sure that you document in your note that it is not flexor tenosynovitis. It is something else. So you really want to rule out these 4 signs. And then you want to determine the chronicity of it, because remember that oftentimes you're going to see flexor tenosynovitis that may be 2 or 3 weeks old, that already has pus in there, that it's already draining from the wound. That's not an emergent case. It's more like an urgent case of a potential amputation or a washout. Compartment syndrome in the hand is pretty rare. The times that I've seen it has been related to bad crush injuries, electricity, or burns. There are 10 compartments in the hand. And they do require extensive releases, so you're releasing the dorsal and palmar interossei, the thenars, hypothenars, the adductors, and the carpal tunnel. You will see a rock-hard hand. Typically, the patient is numb in all nerve distributions. And while you can striker these compartments, most likely 99.9% of the time, this is really a clinical diagnosis. Acute carpal tunnel syndrome you will see a lot more. It's usually related to high energy distal radius fractures or other high energy injuries like perilunate or lunate dislocations. And what's important to discern is, was the median nerve injury due to the injury itself, so like a neuropraxia from a stretch injury with a significantly displaced distal radius, or is it due to bleeding in an enclosed space, which is an involving carpal tunnel? So your job is to say, did this happen from the minute the injury happened, or has it been progressive over the last few hours? You want to get the distal radius or the injury reduced and then reassess an hour later. So elevate, 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 ice, and then reassess the patient. So this is more like the injuries that you're going to see that show acute carpal tunnel. It's the perilunate injuries, or in this case, a scaphoid annulunate injury. Where they're going to have swelling that shows they maybe come in with doing normal, but they're starting to get more and more numb over the hours, and they go to surgery for a carpal tunnel release and potentially reduction, or at least a carpal tunnel release and delayed reconstruction. High pressure injection injuries, so these are rare, but you will see them. But what you need to know is that it looks pretty benign, but it is overall pretty bad. It's essentially compartment syndrome of the finger and potentially the hand, because if it's oil-based paint or any solvent that is highly reactive, it's going to cause a very noxious reaction in the hand. The higher the pressure of the injection, the worse off it is. The longer from the diagnosis to time of surgery, the higher the risk of amputation is, the higher the velocity. And then the location of the injection makes it worse. So if it's in the digit, it's worse in the palm. So all these things you want to document. So what solvent it is, what the pressure was. These people typically know these injuries, and then you call us to get them to the operating room. Moving on to hand urgencies. So open fractures, typically of P1, 2, metacarpals, carpus, and radius. So these we want to know about more often than not. We tend to treat these with oral antibiotics and follow up depending on kind of the mechanism of the open fracture and the extent of the injury, but you can treat these with IV antibiotics versus take into the OR. It's usually an attending preference for this. Wrist lacerations in a perfused hand, fight bites, deep abscesses. Right, so when you think about these, what you really want to think about is, in the fight bite setting, how chronic is it? Right, these are usually the ones that are like pending pus evolution. We would like to take them to the OR before the pus happens in an urgent situation. Deep abscesses, we like to take to the OR to decompress, but we do need to know where the pus is, so that means a CT with contrast to help us find out where it is. So hand lacerations, the main questions that you need to know: what vascular structures are injured, what nerves are injured, what tendons are injured, is there bone injured? So anytime you see a laceration, just go through those 4 things, and that's the answer that we usually want to get. So if you think about these in every single situation, so what bone is injured in the distal tip? You may have some exposed bone here. Most likely no tendon is exposed, no vascular injury, right? In the picture down below, you certainly have an extensor tendon injury. You probably don't have a vascular injury that's requiring surgery, but you may have a nerve injury on the ulnar side of the small finger. And then here on this injury, you say most likely a flexor tendon is injured, potentially a radial digital nerve from this image, and potentially the artery. So what we care about is where's the laceration, what's a vascular nerve, tendon, and bone injury, right? Think about that every time you see an exam. So flexor tendon lacerations, you don't need to tag the tendon, but we do want you to do a good exam, which typically involves do the sensory exam first, check sensation on both sides of the finger distal to the laceration, check all fingers if there's any chance that the laceration could extend across the palm. I've seen a ulnar-sided laceration that has actually cut the ulnar nerve all the way on the index finger side, so beware of that. But once you've done your sensory exam, you can do a digital block or you can put in local, and then you can check your motor and vascular exam. You'll get a better exam once you've done the patient up. You don't need to tag the tendon. For extensor tendons, same thing goes. On the back of the hand, doing a sensory exam, and then look at the laceration once you've numbed them up. So extensor tendon repairs, you can do a lot more in the ER than you can do with flexor tendons, mainly because there isn't nearly as much retraction and there aren't neurovascular structures that are critical in their way. Most of the time the tendon is sitting there, particularly over the digit, and can be repaired with a 4-0 Ethibond or a 4-0 fiber wire with a horizontal mattress type stitch in the finger. The tendons usually retract more when the laceration is proximal to the junctura, so over the metacarpals. They frequently require surgery because they've retracted at that point. Hand infections. So etiology is mostly related to trauma, bites, drug abuse, animals. Most of the time it's cellulitis, but certainly we see a lot of other infections that are surgical or at least IND-able for you in the emergency room. So just remember fluctuance, warmth, edema, redness, tenderness, right? Look for any lymphangitis. Mark it out. The best thing you can do is take an indelible marker, put the date, put your initials next to it, and circle the erythema. That way we know if we're treating cellulitis, we can make sure that the antibiotics we are giving are working. If it extends beyond that border, then we know that they aren't working and we need to consider something else. All right, so take that marker, check labs initially, and we can follow that over time. Look at an x-ray to see foreign body, gas, any fracture, septic joint, osteomyelitis. So the one thing is, in the setting of an abscess, first time you make an incision, it's going to be small, and then you're going to regret it because it's going to be closed the next morning when you go around on the patient, right? So make the incision at least twice as big as you think you need to. On the back of the hand, you can make very long dorsal incisions without injuring. On the front of the hand, they're usually more like a zigzag type incision. Send a specimen, which is a deep swab, leave the wound open and pack it, right, and do warm soapy soaks. This is a lovely picture of an abscess. I think you all probably have already seen one. Paronychia, so you most often will not get consulted for this. This is usually meant in the ER with warm soapy soaks and antibiotics. If you do need to elevate it, sometimes you can just stick a freer underneath the eponychial fold here and express pus. Occasionally you do need to make a separate laceration to express the pus and get warm soapy soaks and oral antibiotics. Felon, as we discussed earlier, remember these are small compartments in between and you need to open them all up. So you make a longitudinal incision on the either radial or ulnar side, depending on which is going to be most affected by pinch and grip. And you spread and you spread and you spread, and it feels like you're deflating a balloon, but what you're doing is decompressing each one of those pockets. So we typically recommend radial or ulnar-sided incision. Do not do the fish mouth tip incision at the top and then decompress it. You're going to see cat bites, dog bites, spider bites, and I put those in quotes because who knows what type of bites they are, right? And frequently human bites, from fight bites to the 3rd, 4th, or 5th MCP joint. Remember, it's typically staph and strep, right? You can see Eikenella and human. We wash them out and we leave them open to pack them. Here's a nice fight bite that actually had what looked like a surgical incision, but it was pretty big. So that pretty much encompasses most of the consults that you're going to see. I just want to go over quickly some local or regional blocks if you have a question. So when you think about a digital block for the finger, this is the dorsum of the hand, and the radial side is innervated by radial, ulnar side is innervated by ulnar nerve. If you look at a lateral of the finger, there are dorsal digital nerves and there are volar digital artery and nerves. And so the goal is to inject to numb both the dorsal digital nerve and the volar digital nerve. So when I do an injection, I come in on the dorsal side of the finger, right? So you can come in on the volar side and do the same thing, but my preference is to come in on the dorsal side on the radial and ulnar aspect of the MP joint, and I stick a needle in, and you're going to use 10 cc's of lidocaine or lidocaine with epinephrine. And what I'd say is initially go down and go all the way to the volar surface and inject 3.5 cc's volarly, and then pull back and inject 1.5 cc's dorsally. Then drop your needle, as you can see in C, go across to the other side to make that nice and numb, and then pull your needle out and re-inject volarly again 3.5 cc's. So that's a total of 10 cc's for a digital block. This is if you're coming in volarly and you just are trying to get the common digital nerve. When you think about tourniquets, this is a consideration for what you may want to use for a tourniquet. I prefer to use a 1/2-inch Penrose drain to S-mark a finger. You start and you use it just like an S-mark, and then you clamp it off down here. The nice part is when you use an S-mark is that if you use a Penrose is that you can see it here. You're never going to forget about it. You put a clamp on it, so a patient is never going to leave the operating room or is never going to leave the ER with a clamp attached to them. Versus this, in this picture, you see it's a glove, and you just roll it down like this. Now, I highly suggest if you're going to do this, put a clamp on this so that you don't forget about it. I have seen a case once where a patient was sent home with a digital tourniquet on, right? It's always very concerning in that setting, but put a clamp on it so that you don't forget about it. The Penrose drain works really well because it does act as an S-mark for the finger, so it's like a venous tourniquet. So last thing I want to talk about here today is just splinting the finger. So you will almost never go wrong if you splint somebody in the intrinsic plus position, and this is just an image of the intrinsic plus position. So here the wrist is extended about 20 degrees, the MPs are flexed 90 degrees, and the IPs are in extension. So if you have any doubt about how to splint somebody, splint them in this position, right? This, you can even do this for a flexor tendon, but extensor tendons go in full extension like a pancake splint, like just totally flat. But most of the time in the setting of a fracture, you're not going to go wrong if you splint somebody like this.